So in our previous year NEET question discussion series, today we will discuss 5 questions from NEET 2025 from the Department of Cardiology. Okay, so let us solve this question. Always when you are solving a NEET question, we have to read from the last line. So the last line reads as, what is the most appropriate initial management? So we have to read the first 3 lines to find out what is the diagnosis, and we have to think of the management. A 64 years old male presents with palpitation and an irregular pulse. He presents within 2 hours of symptom onset and has no history of diabetes or any other comorbidities. So let us decode this question one by one. A patient is presenting with palpitations. The clue given here is he has irregular pulse. So only one condition produces irregular pulse, which is atrial fibrillation. So this is a 64 years male having atrial fibrillation. And the next clue here is the onset of symptom is less than 2 hours. And he has no history of diabetes or other comorbidities. So why this is important is, as you all know, by the cause we can classify atrial fibrillation into valvular atrial fibrillation and non-valvular atrial fibrillation. By the duration again, atrial fibrillation can be classified in different ways. It's an acute atrial fibrillation, persistent and chronic. So we are not discussing the time durations. When the onset is less than 48 hours, it is usually called as acute atrial fibrillation. More than 48 hours to 7 days, it is persistent. So this is actually an onset is only 2 hours. So it is an acute non-valvular AF, because they are given the onset is 2 hours and he has no other comorbidities. So we are having a case of acute non-valvular atrial fibrillation. So what is the most appropriate initial management? So if you think of the management of atrial fibrillation, it is of 3 steps. And the 3 steps come in order. The order is rate control, anticoagulation, and rhythm control. Rate control, anticoagulation, and rhythm control. So the first step which we have to do is rate control. So rate control, just think of the mnemonic ABCD. Okay, in any arrhythmia question, think of the mnemonic ABCD. A for adenosine, B for beta blocker, C for calcium channel blocker, and D for digoxin. The note here is adenosine has no role in treating atrial fibrillation. It comes in the management of SVT, supraventricular tachycardia, or in other words it is called as AVNRT, atrioventricular nodal reentrant tachycardia. Just remember the term SVT. Adenosine has no role in management of atrial fibrillation. So this is out. So either we can give beta blocker in this case, or a calcium channel blocker in this case, or digoxin in this case. Calcium channel blocker, if you remember, it is of 2 categories: DHP, that is dihydropyridine calcium channel blocker, and non-dihydropyridine calcium channel blocker. Anything which ends with dipin, dihydropyridine or dipin, is called dihydropyridine category. Amlodipine, nifedipine, it's a dihydropyridine. This dihydropyridine calcium channel blocker is mainly used in treating hypertension. Whereas we have 2 main non-dihydropyridine calcium channel blockers. One is verapamil, The other one is diltiazem. Okay. So we have many beta blockers, like injection form comes as esmolol. It is the very rapid acting beta blocker. Its half-life is very small. It is less than 6 minutes. We have other calcium channel blockers like metoprolol, carvedilol. We'll stop here, and D for digoxin. So we'll read the options one by one. So TE is trans-esophageal echocardiography for starting anticoagulation. Trans-esophageal echocardiography is a better investigation to pick up left atrial clots. If a left atrial clot is present, we have to anticoagulate before controlling the rhythm. Because once you control the rhythm in atrial fibrillation, whatever clot is present in the left atrium will dislodge and cause a stroke, cardioembolic stroke. That is why doing trans-esophageal echocardiography is important. But according to the question, is it the appropriate initial management? No, because anticoagulation becomes very important when atrial fibrillation is more than 48 hours of onset. Here it is clearly 2 hours, so there is no time window for anticoagulation. Also, we have to do anticoagulation when it is a valvular AF. So, valvular cases, we must give anticoagulation. When atrial fibrillation is more than 48 hours of duration, we have to give anticoagulation. In non-valvular and atrial fibrillation, we have a score called as Chad-Vask score. Okay, if you remember, C for congestive heart failure, H for hypertension, A for age more than 74, D for diabetes, S for stroke. The stroke carries 2 points, age more than 74 carries 2 points, V for any vascular abnormalities. Again, the next A stands for age between 65 to 74. The SC stands for sex category of female. So whenever you are given a case of non-valvular AF and questions comes on anticoagulation, just remember this Chad-Vask score. Age more than 74 and stroke carries 2 points, and remember that also. If the score is 0, you need not anticoagulate. When the score is 1, they say we can give aspirin or anticoagulant. When the score is more than 2, we must anticoagulate. Okay. So since this is a non-valvular AF, what is the Chad-Vask score? This is a 64 years male. So no comorbids are given in this patient. So he does not have congestive heart failure. He does not have hypertension. His age is 64. So these two categories also do not fill. Here it does not have diabetes. There's no stroke, no vascular abnormalities, and he is a male. So automatically in this case, Chad-Vask score is 0. So even if it is a non-valvular AF, there is no indication for anticoagulation. You need not actually calculate Chad-Vask in this case because the time interval is only 2 hours and it is an acute onset AF, so straight away there is no indication for anticoagulation. Cardioversion. Cardioversion is a method used to control rhythm. So it comes as the last step. Cardioversion is, or rhythm control, is of 2 types, which is chemical cardioversion or electrical cardioversion. Chemical cardioversion is by using some medicines called as amiodarone, dronidarone, ibutilide, dophytilide. Some questions can come, which is the chemical cardioverter. in atrial fibrillation. So one of these options will come, right? Electrical cardioversion is otherwise the shock. So since the question asked here is initial management, even though rhythm control comes here or cardioversion comes here, it is not the initial management. In it, every word is important. And the third one is control ventricular rate with verapamil. So this is what we discussed. The first step in atrial fibrillation management is rate control. And among the rate control agents, we have B, C and D. Beta blocker, calcium channel blocker or digoxin. And verapamil is a non-dihydropyridine calcium channel blocker. So this answer seems appropriate. Even though this seems appropriate, always we have to go through the other options. Option D is wait and watch. Of course, this is not the option because he is symptomatic, we have to manage, right? So atrial fibrillation is a very important area in NEET. So we just covered how to classify atrial fibrillation, what is valvular AF, what is non-valvular AF, and the drugs used, and the basic approach, right? So coming to the next question of NEET 2025 cardiology. Again, we have to read from the last line. Which of the following investigation can pick up the etiology in this case? Again, it's a case scenario. We have to understand the case scenario, decide the diagnosis, and decide the treatment. A patient presents with sudden onset aphasia and right-sided arm weakness for the past 4 hours. He has a past history of rheumatic heart disease with severe mitral stenosis. So, seems a simple and straightforward one. Sudden onset aphasia and right-sided arm weakness. Whenever something is sudden in neurology, it is a cerebrovascular accident or a stroke. Whenever something is sudden in neurology, it is CVA or stroke. So we are having a case of stroke with the right monoparesis plus aphasia. They have not given what type of aphasia, but we are having a right monoparesis plus aphasia. Usually right monoparesis or a right hemiparesis and aphasia go together because usually the left side of the brain is the dominant brain and the language centers, that is Broca's area and Wernicke's area. Broca's area is area 22, Wernicke's area is area 44. Broca's area is the area for speech or the motor component of the speech or the fluency of speech. Wernicke's area or area 44 is the area for comprehension. Broca's area is located in the frontal lobe. Wernicke's area is located in the parietal lobe. So Wernicke's area is located in the parietal lobe, area 44. Broca's area is located in the frontal lobe, area 22. Wernicke's area is for comprehension of speech. Broca's area is for fluency of speech. Please remember, these two areas are located in the dominant hemisphere of the brain. Okay, these two areas located in the dominant hemisphere of the brain. For most people, the left side is the dominant hemisphere of the brain. So when there is a stroke in the left side, automatically it causes right-sided hemiparesis or monoparesis. That is why these two go together. So this patient is having a right-sided monoparesis plus aphasia, which means he is having an infarct or a hemorrhage, that is a stroke of the left side of the brain involving one of these two areas, right? So it is clearly a stroke. Even if you don't understand the location, you need not know the location in this case because the diagnosis is clear, it's a stroke. And there is a past history of rheumatic heart disease with severe mitral stenosis. So this is a clue regarding the etiology in this case. So etiology of stroke is classified basically into two. We have ischemic stroke and hemorrhagic stroke. Ischemic stroke is of two types: embolic, thrombotic. Of these three, embolic stroke is the most common type of stroke. Embolic stroke is the most common type of stroke. So what type of stroke this patient may have? They have given a clue, rheumatic heart disease with mitral stenosis. In the last question we discussed, atrial fibrillation is of two types. We have valvular AF and non-valvular AF. Valvular AF we must give anticoagulation because the chance of clot formation and formation of a stroke is very high, right? So this patient is having rheumatic heart disease, so he may have a valvular AF and he may have an embolic stroke. So the probable diagnosis in this case is a valvular AF with atrial fibrillation causing an embolic stroke. Now the question will become very simple. What is the investigation to pick up cardioembolic stroke? Carotid and vertebral Doppler. This Doppler will help us to locate clots or any stenosis in the carotid and vertebral vessels. This will pick up thrombosis. So this is an investigation for thrombotic stroke. Transesophageal echo, of course, it has a role in rheumatic heart disease to pick up clots in the left appendage or left atrium. So this seems inappropriate. In NEET, always read all options before coming to the conclusion. Transthoracic echo. Transthoracic echo is the echo we commonly come across. The echo probe is placed across the chest. Okay, this is also important, but when there is a comparison between transthoracic echo and transesophageal echo, transthoracic echo may miss some left atrial clots which is picked up by transesophageal echo. So this may be done, but it is not so appropriate when compared to transesophageal echo. So we will exclude this option. MRA brain. Of course, MRA brain is the diagnosis of choice or investigation of choice to pick up stroke. Whatever be the type of stroke, ischemic stroke or hemorrhagic stroke, MRA is the investigation of choice. Especially when the onset of stroke is less than 6 hours, MRA brain is good because it can find out early in fact. But if someone asks the question in NEET, what is the initial investigation of choice? The better answer will be CT brain. Because guidelines say we do not need MRA to decide on treatment of stroke. Basically, if you do a CT brain and it shows an infarct, or to be more precise, if it does not show a hemorrhage, we can treat it as an ischemic stroke. That is what guidelines say. Plus, MRA brain is time consuming, it takes around 1 hour, whereas CT brain is a rapid test, it takes only 5 hours. So when the patient comes in the window period of stroke, which is less than, when the patient comes in the window period of stroke, which is less than the 4.5 hours of time limit, you should not waste time because time is brain. In that case, the initial investigation of choice is obviously CT brain. Suppose CT brain does not pick up an infarct and you have completed the treatment and the patient has crossed the window of 4.5 hours. In that case, MRA may be preferred again to correctly diagnose ischemic stroke. Right? So understand the question whether it is initial investigation of choice or the investigation of choice and look at the time intervals before answering this question. So this patient is 4 hours. He comes under the window period of stroke. So MRA brain is not so ideal. CT brain is ideal, not to waste time. So, but still MRA brain is an option. So now the thing is we have to decide between whether MRA brain is the answer or transesophageal echo is the answer. Read the question, which of the following investigation can pick up the etiology of this case? MRA brain finds out the diagnosis, it is stroke or not, whereas transesophageal echo finds out the etiology, which is embolic stroke. So TE will be the better option here. So please remember in NEET every word is important, right? So you can read the question 2 times. They have asked the etiology, which investigation picks up the etiology of this case, right? So TE will be the answer. Now, how will you manage this case? So we didn't discuss this in the last case. We discussed about the rate control options and we discussed about the cardioversion rhythm control options of AF. Now what about the anticoagulation? As already discussed, anticoagulation in atrial fibrillation should be done for any case of valvular atrial fibrillation to prevent cardioembolic stroke. Next, it should be done in non-valvular AF when the CHA2DS score is 2 or more. CHA2DS score is 2 or more than 2 and can be given when there is an RST with previous history of stroke that is ischemic stroke. The side effect of anticoagulation is hemorrhage. So when there is a previous history of hemorrhagic stroke, this is contraindicated, and patients who are taking anticoagulation for ischemic stroke may develop a complication of hemorrhagic stroke. So that can also be given as a scenario, so please be careful. What are the options available for anticoagulation? Again, we have a category called VKA, vitamin K antagonist. If you have to remember one name here of vitamin K antagonist, remember warfarin. Okay, warfarin is very important in pharmacology because it has so many drug interactions, it has so many protein binding. So we can discuss that in pharmacology. And the other option is NOVAC or DOVAC. That is new oral anticoagulants or directly acting oral anticoagulants. Why the term directly acting oral anticoagulant? When you come to the pathway of coagulation, you would have heard about the terms extrinsic pathway, intrinsic pathway of coagulation, and both merge into the common pathway, that is factor 10. So whether coagulation gets activated by extrinsic pathway or intrinsic pathway, it finally ends into factor 10, where factor 10 gets converted to activated factor 10. This converts factor 7 to activated factor 7, and this converts factor 2 to activated factor 2. Factor 2 is prothrombin. So even if you don't remember the other factor names, just remember factor 2, it is prothrombin, gets converted to thrombin. So DOVAC is directly acting oral anticoagulants. These category of drugs directly inhibit factor 10A, whereas vitamin K antagonists, they inhibit vitamin K. You would have known the vitamin K dependent clotting factors 2, 7, 9 and 10. These are the vitamin K dependent clotting factors. So vitamin K does not inhibit factor 10 or factor 7 or factor 2 directly. Vitamin K antagonists inhibit vitamin K, hence these vitamin K dependent clotting factors are not produced, hence clotting does not happen. Whereas the category NOVAC or DOVAC directly inhibits the factor 10. So what are the drugs which are available? Apixaban, rivaroxaban, edoxaban, and another drug is dabigatran. Even if you get confused with the name in the exam, just see the clue here, XA. XA is nothing but 10A, activated factor 10A. So this apixaban, rivaroxaban, edoxaban all have XA in their name. So these three drugs inhibit factor 10A. They directly inhibit 10A. Dabigatran is also a directly acting oral anticoagulant. Again, see from the name, it is TRAN. TR is thrombin antagonist. Right, so dabigatran inhibits thrombin. Thrombin is factor 2. Right, so the directly acting oral anticoagulants may be factor 10A inhibitors or factor 2A inhibitors. factor 10A inhibitors comes with the name XA, apixaban, rivaroxaban, edoxaban, and factor 2A inhibitors or thrombin inhibitors or direct thrombin inhibitors comes with the name TRAN, dabigatran. Okay, so these are the options for anticoagulation, and this completes the discussion of this case. Now coming to question 3 of previous year NEET question 2025 in Cardiology department. So to solve this case, again we have to read from the last line. Which of the following is the most appropriate agent to add to his current regimen? So we understand that some drugs will be given in the question. We have to think of any drug which has to be added extra. A 60-year-old diabetic patient is currently on metformin and insulin mixture. His HbA1c is 9%. Echocardiogram shows ejection fraction of 32. So we'll write down the clues here. So an elderly patient, 60 years old person, is having diabetes and he is on 2 drugs, metformin as well as insulin, and his HbA1c is 9. So please remember, the normal HbA1c is less than 5.6%. Normal HbA1c is less than 5.6%. When HbA1c is more than or equal to 6.4%, it is labeled as diabetes. The values in between 5.6 to 6.3, okay, 5.6 to 6.3, it is as pre-diabetes or impaired glucose tolerance. So less than 5.6 HbA1c is normal, more than or equal to 6.4 HbA1c is called diabetes. Values between 5.6 and 6.3 is impaired glucose tolerance or pre-diabetes. To say a controlled diabetes, HbA1c has to be less than 11. To say controlled diabetes, HbA1c has to be less than 7%. This patient is having HbA1c of 9, which means despite taking 2 drugs, he is having uncontrolled diabetes. So we are having a 60 years male with uncontrolled diabetes despite 2 drugs. So we have to add a new anti-diabetic drug. His ejection fraction is 32. Ejection fraction is a finding which is picked up in an echo, which is the pumping capacity of blood. So EF is less than 32. So this would have been discussed in physiology. Ejection fraction, something tells about the pumping capacity of the heart. In medicine, just remember the term heart failure. Heart failure is failure of the pumping capacity of the heart, or a problem with the pumping of the heart. Arrhythmia is a problem with the rhythm system of the heart. Heart failure is a problem with the pumping system of the heart. Coronary artery disease is a problem with the vascular system of the heart. Right? So when EF is 32, it's a problem with the heart failure or the pumping capacity. Based on ejection fraction, they have classified heart failure into 3 categories. Heart failure with reduced ejection fraction, where ejection fraction is less than 40%. We have heart failure with preserved ejection fraction, HFpEF, where EF is more than or equal to 50%. Then we have the mid-range heart failure with mid-range ejection fraction, where EF is between 40 to 50. So this patient, by the example, they are given EF is 32. So he comes under the category of heart failure with reduced ejection fraction. Whenever there is a heart failure with reduced ejection fraction, there are something called as pillars of heart failure. Even if this seems too much to you, just hear these names once. There are 5 pillars of heart failure: ACE inhibitors or ARBs. ACE inhibitors, angiotensin converting enzymes inhibitor, all the drugs which end with the name pril, like enalapril, captopril, ramipril, anything which ends with pril is an ACE inhibitor. ARBs, angiotensin receptor blocker, anything which ends with sartan, so like losartan, telmisartan, olmesartan. These are ARBs. Remember, these act on the sequential steps. So you know very well that angiotensin converting enzyme converts angiotensinogen to angiotensin. That angiotensin acts on angiotensin receptor to have its effects on vasoconstriction. So angiotensin converting enzyme and ARBs inhibit sequential steps. So these two should not be given together. So the second pillar of heart failure with reduced ejection fraction is the beta blocker. The third pillar is aldosterone antagonist. They say as mineralocorticoid receptor antagonist. Remember one drug name, aldosterone. The drug is spironolactone and eplerenone. Spironolactone and eplerenone. These are the two mineralocorticoid receptor antagonists or aldosterone antagonist. The fourth pillar is ARNI. ARNI stands for angiotensin receptor blocker plus neprilysin inhibitor. So I already told you any angiotensin receptor blocker ends with the term sartan. So I will take one example, valsartan. This neprilysin. Neprilysin is a substance which breaks down angiotensin. Okay, neprilysin is a substance which breaks down Neprilysin is a substance which breaks down the ANP, atrial natriuretic peptide. So remember atrial natriuresis. Natriuresis is the process by which sodium is excreted from the body, which is doing good to the body by reducing blood pressure and volume overload. So when neprilysin gets inhibited, ANP is not destroyed. So ANP increases. When ANP increases, again it is doing good to the body. So one example for neprilysin inhibitor is sacubitril. So ARNI is nothing but a combination of two medicines. Angiotensin receptor blocker, which is doing good by blocking angiotensin 2, and neprilysin inhibitor is another drug which is doing good to the body and blood pressure by reducing the degradation of atrial natriuretic peptide and increasing its level. So sacubitril valsartan is its name. So this may be asked in pharmacology. Okay, so coming to pillars, ACE inhibitors are ARBs, beta blockers, mineralocorticoid receptor antagonist ARNI, and the fifth pillar is SGLT2 inhibitor, sodium glucose cotransporter 2 inhibitor. If you remember physiology, SGLT2 is a channel which is present in the proximal convoluted tubules of kidney, and the name suggests sodium glucose cotransporter. The function of SGLT2 in kidney is to reabsorb sodium and glucose from the tubules to the blood from the proximal tubules of the kidney. So since glucose is reabsorbed by this channel, when it is inhibited, the excess glucose is excreted by the urine. So it is an anti-diabetic drug. So SGLT2 inhibitor is an anti-diabetic drug. By excreting sodium and glucose, what does it do? It can reduce the BP. So it is good for the heart and it is good for the kidney. Okay, so it is cardioprotective and nephroprotective. So that is how this drug is useful. So SGLT2 inhibitor is an anti-diabetic, it is cardioprotective and it is nephroprotective. So the examples for SGLT2 inhibitors is anything which ends with flozin, dapagliflozin, empagliflozin, anything which ends with glyphlosin, canagliflozin. So where we started? We started with the 5 pillars of heart failure. SGLT2 inhibitors is one drug, which is an antidiabetic, which is a pillar for heart failure, as well as it is nephroprotective. So we'll read the options. Pioglitazone. Don't get carried away by the name. Pioglitazone is an anti-diabetic drug which is a PPAR gamma agonist. It is one drug apart from metformin which helps in insulin, helps to treat insulin resistance. It is also called as insulin sensitizer. So if someone asks you the question, which are the insulin sensitizers or which are the drugs used for insulin resistance, we have two. One is metformin and other one is PPAR agonist, PPAR gamma agonist. Remember, there is another category of drug called PPAR alpha agonist. These are actually drugs used in dyslipidemia, hypercholesterolemia. We have something called saroglitazar. It is a drug used in fatty liver. It is both PPAR alpha and a PPAR gamma agonist. Okay. So pioglitazone is a PPAR gamma agonist used in diabetes. Glimepiride is a sulfonylurea. Sitagliptin is a DPP4 inhibitor. Again, it is an anti-diabetic drug. Dipeptidyl peptidase 4 inhibitor. So what is this dipeptidyl peptidase? Dipeptidyl peptidase is an enzyme which breaks down GLP-1. So in recent days you would have heard about GLP-1 receptor agonist, semaglutide, tirzepatide. These are drugs which are used in weight loss and in diabetes. So DPP4 is a peptide which breaks down GLP-1. When DPP4 is inhibited, GLP-1 increases. Remember, GLP-1 is a insulin secretagogue. It helps to secrete insulin. Okay. So sitagliptin is actually a good drug, but remember, the one drug which is used in heart failure among anti-diabetic drugs is SGLT2 inhibitor. So it is empagliflozin. Right? So this question is about heart failure and anti-diabetic drugs. We just combined both. So let us go to the next question. Let us go to the next question in previous year NEET question discussion of NEET 2025 Cardiology. So as usual, we'll start with the last line. Which of the following is the most appropriate preventive treatment? So a diagnosis has to be picked up and we have to tell about the preventive treatment. Okay. So a patient arrives at the emergency department with sudden onset palpitation. So when it is palpitation, remember we are having some arrhythmia and chest tightness. ECG confirms the diagnosis of PSVT. So sometimes they may give an ECG. If an ECG is given with this history, palpitation, chest tightness and arrhythmia history, high heart rate, just you have to see two things. Obviously, when there is tachycardia, the ECG is going to be fast. You are just going to see the QRS complex. When the QRS complex is narrow, so see this case, narrow in the sense this is narrow. It looks narrow. Thus, the actual way to say narrow is the entire QRS duration is less than 3 small squares. I am not telling the actual values because when the ECG is given, we are obviously going to count the number of squares. When the QRS duration is less than 3 small squares, we call it as narrow complex. So when there is a tachycardia or an arrhythmia with narrow complex, it is called as narrow complex tachycardia. Similarly, when an ECG is given with the wide complex, see this one looks obviously wide. To say wide, the QRS duration should be more than 3 small squares. This is obviously more than 3 small squares. So when there is a tachycardia or an arrhythmia with wide QRS complex, we call it as wide complex tachycardia. There are some arrhythmias which are narrow complex tachycardias. There are some arrhythmias which are wide complex tachycardias. Remember, anything which is above the ventricle, supraventricular origin is supraventricular tachycardia. They are narrow complex. Anything which originates from the ventricle is wide complex tachycardia. Example, ventricular tachycardia, ventricular fibrillation. They are wide complex tachycardias. Anything which comes above the ventricle is commonly labeled as supraventricular tachycardia. There are many types like atrial flutter, atrial fibrillation, the so-called AVNRT. Common SVT is AVNRT and atrial fibrillation. Okay, so we are not going in detail. Atrial fibrillation, we have the clue, right? We have already discussed a question on that. Irregular heart rhythm. Atrial flutter, the ECG shows a peculiar pattern called sawtooth pattern. Okay, when you have time, please see the ECGs. It will be easy to recognize as a last minute revision in it. But when common term SVT or PSVT, paroxysmal SVT is used, it stands for AVNRT. So similar to these terms, in wide complex tachycardia also we have ventricular fibrillation, ventricular flutter and ventricular tachycardia. The treatment for both is different. Okay. So here ECG is not given, so we don't have the burden of differentiating wide complex tachycardia versus narrow complex tachycardia. They have directly given the diagnosis is PSVT, paroxysmal supraventricular tachycardia. So it has to be a narrow complex tachycardia. Which of the following is the most appropriate preventive treatment? Okay, so we have options. IV lignocaine. Remember, lignocaine is a drug for treatment of ventricular tachycardia. It has no role in SVT. Next option is verapamil. Remember, verapamil is a non-dihydropyridine calcium channel blocker. You remember we told about the terms ABCD. B is beta blocker, C is calcium channel blocker. In arrhythmias, non-dihydropyridine calcium channel blockers of verapamil and diltiazem are only used, whereas dihydropyridine calcium channel blockers like nifedipine, cilnidipine, amlodipine are used in hypertension. The D stands for digoxin. Okay. I told you when discussing atrial fibrillation, there is no role of A in atrial fibrillation. A stands for adenosine. Adenosine is the drug of choice. For treatment of AVNRT or PSVT, paroxysmal supraventricular tachycardia. So how will you treat PSVT? It is not directly adenosine. The first step is vagal maneuvers. Vagal maneuver is like pouring cold water in the face, immersing in face and blowing out air. So there are some maneuvers called as vagal maneuvers. You need not remember everything. When vagal maneuvers fail, we have to use the drug which is adenosine. Okay, when adenosine fails, we are going to use electrical cardioversion. This is how you treat PSVT. But the question asked here is how will you prevent, right? Again, we are going to give one of the drug. Adenosine cannot be given as prevention because it is an IV drug. Okay, beta blockers may be given, but calcium channel blockers are more effective than beta blockers in this case. Digoxin, even though it is a good drug, it is not commonly used nowadays because it is prone to cause digoxin toxicity. If some question comes giving an ECG mentioning a inverted tick sign, right? So there is something called inverted tick sign, which is a depressed ST segment with a T wave inversion or a hockey stick sign. it is a sign of digoxin toxicity, right? So since the probability of digoxin toxicity, digoxin is not used nowadays. So among beta blocker or verapamil is commonly used as a preventive treatment for AVNRT. That is what this option is. So oral verapamil seems a good option. Again, always in NEET, we have to read the other options before coming to the conclusion. IV adenosine, as I already told you, it is the treatment for AVNRT used as a second line when vagal maneuvers fail. Oral nifedipine. Nifedipine is also a calcium channel blocker, but it is a dihydropyridine calcium channel blocker used to treat hypertension and not used to treat arrhythmias. So lignocaine ruled out because it is the treatment of VT. Verapamil ruled in because it is a arrhythmia treating calcium channel blocker. Adenosine ruled out because it is the treatment of AVNRT. Nifedipine ruled out because it is a antihypertensive. Okay. So in last 2025 NEET, some 2 to 3 questions have come on arrhythmias itself. Like we had a cardioembolic stroke with AF, and we had a treatment of AF, acute treatment of AF, and we had this SVT. Okay, so just summarizing about arrhythmias, we have supraventricular tachyarrhythmias and we have ventricular tachyarrhythmias. Supraventricular tachyarrhythmias are atrial flutter, atrial fibrillation, and PSVT. Ventricular tachyarrhythmias are ventricular tachycardia, ventricular fibrillation, and ventricular flutter. Opposite of tachyarrhythmia is bradyarrhythmia. We have sinus brady. We have atrioventricular blocks. If some questions come across, we'll be discussing that. So please be thorough on at least arrhythmia, a few concepts, right? So we'll discuss another question from NEET 2025 previous year question, cardiology. So again, read the last line, which is the next best test. So some diagnosis has to be picked up and we have to think what is the next level. A 70-year-old man underwent joint replacement surgery 3 days ago. Today he developed sudden onset breathing difficulty with chest pain. On examination, pulse rate was 110 per minute. So there is tachycardia. BP was 90/60. So looks like a hypotension. Respiratory rate was 28 per minute. The normal respiratory rate, when respiratory rate is more than 20, it is called as tachypnea. Respiratory rate less than 10, it is called as bradypnea. Opioid poisoning is an example for a drug causing bradypnea. The triad of pinpoint pupils, bradypnea, and drowsiness is an example for bradypnea. Here we have tachypnea. Just an add-on I told you for because it may be asked as a question. Opioid is important. Okay, and SpO2 was 86% in room air, so there is hypoxia. Right? So patient comes with breathing difficulty with these features. So there are so many diagnoses which can cause this, but we have to pick up some clues. ECG shows sinus tachycardia. So what may be the best possibility? Some people may give an extra clue here in the question itself, like D dimer was high. Actually, the question given in NEET was D dimer was high. I didn't mention it here because I just wanted you to think what may be the possible diagnosis. So there are many conditions which cause sudden onset breathing difficulty, like bronchial asthma acute exacerbation, COPD acute exacerbation. It could be a pneumonia. It could be a pneumothorax. Whenever there's a breathing difficulty, try to find out the clue, clinical clue. Right? For example, a patient with a known bronchial asthma comes with a wheeze. When the climate is cold, it may be bronchial asthma. When a smoker comes with breathing difficulty, it may be COPD. Right? When patient comes with fever and breathing difficulty and these findings, it could be a pneumonia. When a patient comes with chest pain and breathing difficulty, it could be a pulmonary edema of a myocardial infarction. Here, the clinical clue itself picks up. There is a history of joint replacement surgery. When there is a joint replacement surgery, patients has to take bed rest. When someone takes a bed rest, they are more prone to form deep vein thrombosis in the leg veins. So you know the triad, right? Hypercoagulability, stagnant blood, and endothelial injury. The which was tried, when it is there is more chance of thrombus formation. So when patients take rest, there is obviously a stagnation of blood there. So it can lead to DVT. When DVT follows the track, that is, when from the veins it goes into the IVC and SVC join to form the right atrium. The blood from the right atrium goes to the right ventricle. You know very well that pulmonary artery, the main pulmonary artery, begins from the right ventricle. The main pulmonary artery divides into two branches, which is right pulmonary artery and left pulmonary artery. So even though there is a vein thrombosis which is forming in the leg veins, through IVC, through right atrium, through right ventricle, through pulmonary artery, it can block one of these pulmonary arteries. So when the pulmonary artery is blocked, what happens? The blood from the ventricle cannot be pumped into the lungs. When blood is not pumped into the lungs, what happens? Even though the lung is ventilated with air, since the perfusion of blood is not there in the lung, there occurs a mechanism called VQ mismatch, ventilation perfusion mismatch. So blood is not flowing, the perfused blood, so oxygenation of blood is affected, so this leads to hypoxia. Right? This is how pulmonary embolism, by blocking blood flow to the pulmonary artery, reduces blood flow to the lungs, reduces the perfusion, and hence causes VQ mismatch leading to hypoxia. In pulmonary embolism, D-dimer is high. Remember, D-dimer is one of the fibrin degradation products in clotting mechanism. Right? So given the clinical clue of history of a joint replacement surgery and a bed rest with sudden onset breathing difficulty, clinically this looks like a pulmonary embolism. The most common, this is also an MCQ, the most common ECG finding in pulmonary embolism is sinus tachycardia, which is given here. The heart rate will be very high, more than 100. But we have another question. The most specific or the most characteristic finding of ECG in pulmonary embolism is S1, Q3, T3 pattern. S1 is in lead 1, there is S wave. Q3 is in lead 3, there is Q wave. And T3 is in lead V3, there is T wave inversion. Okay, so this is the most specific finding of pulmonary embolism, S1, Q3, T3. But since now NEET questions are becoming more clinical, it is more likely that you may get a question of sinus tachycardia alone. Because the most common ECG finding in pulmonary embolism is sinus tachycardia. So the actual question in NEET was, they are given the clue directly, D-dimer was high, so the diagnosis is pulmonary embolism. What is the next best test? So we'll read the options. VQ scan is ventilation perfusion scan. I already told you in pulmonary embolism, the mechanism is because of pulmonary artery blockage, there is a ventilation perfusion mismatch. Previously there was a scan to find out that, but it is outdated. So even though most books, old references say VQ scan, do not answer this in NEET. It is an outdated test, right? Echocardiogram. Obviously, we will be doing echocardiogram because when ECG showing abnormality, echo will be done. Echo can pick up some findings in pulmonary embolism like a dilated right atrium, dilated right ventricle, but we'll read the other options. Chest X-ray also can show few findings in pulmonary embolism. Chest X-ray also can pick up, but it is not the investigation of choice. CTPA, CT pulmonary angiography, it is the investigation of choice. It is the next investigation of choice, and it is also the gold standard. So however they ask you the question, CTPA is the test of diagnosis, right? CTPA is pulmonary angiography. We are injecting a dye into the blood and we are imaging the lungs. So when the blood is blocked in the pulmonary artery, it can be picked up. Okay. So we have discussed 5 questions in NEET previous year question on the Department of Cardiology from Medicine. So in the next session, we will discuss another 5 questions from another section. Thank you.